Hi friends, good evening. I'm Dr. Ashutosh Gupta, and today we're going to talk about something about Corpus Callosum, right? So as we know that 3 to 4% of the fetuses they can be at risk to have some major congenital abnormalities. 4 to 5% of the babies they can have some minor variations, and 1 to 2% of the babies they can have some subnormal mental IQ. So meaning that the background risk is something around in the range of 10 to 11%. Right now, let us talk about those major sort of congenital abnormalities which could be sort of detrimental to the well-being of the baby, and meaning thereby that once we pick them up, so meaning thereby that it makes all the sense that probably we might do a deep discussion and genetic counseling, can ask for a second opinion, and then not worth going on further ahead with the pregnancy, right? So corpus callosum is one of the structures which usually gets formed, and therefore, so there could be two part of corpus callosum. One is called as a CACC, and second is called as a PACC. So CC is corpus callosum, and CACC meaning thereby that complete agenesis of corpus callosum is the one part. So meaning thereby that we are contemplating that probably the corpus callosum has not formed in toto. Partial hypoplastic dysplastic corpus callosum, as we know that the corpus callosum gets formed over the period of time, and therefore we can have some sort of an ischemic insult, and therefore this can be identified in 5 to 7% of the babies and all those stuff, and the diagnosis is usually delayed, and therefore they might need some further evaluations and MR so as to confirm and to corroborate the ultrasound finding and to confirm the diagnosis that we are dealing with some hypoplastic corpus callosum. Now, let us keep our focus onto a CACC itself. So, for corpus callosum, I have been telling this for the last so many years is this that there could be some direct and indirect findings so as to see and contemplate about the corpus callosum. So, a direct finding is this that you keep the baby in a mid sagittal view, try to identify the corpus callosum, and try to look around in the complete toto, and plus we can try to look around a pericallosal artery, and therefore we can have some sort of an sulcation defects also, and the sunburst appearance of the pericallosal artery, and then the pericallosal artery is absent, and all those stuff, blah blah blah. So now let us first see these images. And then we'll talk about the sort of an indirect signs, how they can really help us in reaching to a diagnosis of a CACC. Okay. So look closely. So this is a 20-weeker fetus, and we are seeing it for the first time. So we can see that there is a cavum septum pellucidum or CSV is not being visualized. We are identifying that the frontal horns are divergent, and we are identifying a trilaminar structure. We are identifying a high riding third ventricle. There is in predominance sort of an dilatation of the posterior horn called as a colpocephaly, right? So bilateral colpocephaly is there. So this is the colpocephaly, and then the CSP is conspicuously absent. And then we can have a teardrop ventricles. So predominantly we are having this colpocephaly. So this is the colpocephaly, and then if we focus, we can have a teardrop ventricles. And this is the high riding third ventricle. The CSP is being absent. So that is giving us the whole idea of complete agenesis of corpus callosum, right? So during my experience of something around 20 years, we have really followed this corpus callosum to a great extent. Earlier, we used to do an array, then probably we have offered them exomes also. But net what we have identified is this that this could be associated with a lot of genetic syndromes to the tune of something around 12, 15 genetic syndromes can be associated to this. So there could be some 10 to 11%. There we can have some chromosomal abnormalities and single nucleotide polymorphism associated with corpus callosum. So whenever we are dealing with this CACC, the usually the prognosis to the baby is not that great, and it is guarded. And we try to look around other congenital abnormalities to the baby if we can identify one of them. So we could not identify any one of them, right? So as we move on further, this is the 20 weeks. So as we move on further, so probably what we can have is that we can have some those periventricular, we can have some sulcation defects, we can have cobblestone lesencephaly, we can have some sort of a nodular heterotopias and all those stuff. But but as far as this corpus callosum is concerned, so there are some direct and indirect ways of identifying to it. Okay, so CSP, absent CSP, and then we can have in divergent frontal horns, we can have an high riding third ventricle, we can have a preferential colpocephaly, and then we are having a triadrap ventricles. This is the non-direct ways of identifying it to be So the very strong suspicion for a CACC. And then we try to maneuver the baby into sagittal view. If need be arise, we can do a TVS so as to identify the corpus callosum. And then we need to see the corpus callosum in total. We can even look around for a pericallosal artery. We can even try to look around for an interhemispheric cyst or an interhemispheric lipomas, which becomes very, very pathognomic for CACC, right? So CACC is definitely one of the sort of an straightway diagnosis that probably we can really attempt to make it in only one go. As far as this PACC is concerned, even though I have earlier also I have made some videos regarding this thing, so we usually tend to keep the baby in a follow up. So meaning thereby that all those things which are not that overt at the moment at 18 19 weeks, which might become overt in 3 to 4 weeks, so meaning thereby that probably we can give the benefit out to the baby to so as to so that we can see the corpus callosum in toto, and or otherwise the colpocephaly becomes more prominent and the heading third ventricle also becomes more prominent. But this is a classical case for a CACC by looking around for indirect signs. So why just I wanted to press upon or to make this video is this, that for a corpus callosum the indirect signs are valid enough and good enough really to really reach to this diagnosis of a CACC, right? And eventually we would need to do a sagittal view to the baby so as to identify, try to look around for the corpus callosum as well as the pericallosal artery, right? Thank you very much for your patience.